to 17 days for the egg to mature into the adult female mite. And normally the mite burden in a patient with classic scabies is approximately 10 to 15 in contrast to the patient with crested scabies. It reaches up to millions of mite in a single individual, and that's due to why the transmission rate is high in those patients with a crested scabies, and the mite is unable to survive off the host at room temperature for more than 48 to 72 hours, but are relatively colder and high humidity, as well as in those patients with a crested scabi. This the mite will survive more than 72 hours. So for now, let's go into the clinical presentation of scabies. Normally, this scabies this scabies can have both typical as well as atypical presentation. So the typical or the classic scabi takes about 4 to 6 weeks for the incubation period before the clinical presentation begins. And the prominent clinical feature of classic scabies is generalized and intense itching, which is worse at the night time. However, in a previously infested individual, the symptoms usually occur within after 1 to 3 days of infestation, and the pruritus in scabies is usually assumed to result due to the delayed type hypersensitivity reaction to the mite and its product, as well as the mechanical effect of the burrowing of the mite into the skin. So the typical cutaneous findings are multiple small erythematous and excoriated papules and burrows. These burrows are the pathognomic signs for scabies. As we all know, these burrows, they present as skin-colored to erythematous serpiginous grayish trail-like elevation in the superficial epidermis, and it's assumed to be due to the
Sorry, doctor, earphone ምናምን እየተጠቀምሽ ከሆነ ብታረጊ ኢኮ ነገር አለውና
Okay, I'm not using any earphone.
Okay, እሺ
So these burrows are the pathognomic signs of scabies, and the cutaneous lesions are distributed symmetrically, typically involving the interdigital and web space of the fingers, the wrist, the axilla, the areola in female, the waistband, as well as the genital area. In the popliteal area, it's the typical distribution in adults, but in children, in immunocompromised, as well as elderly patients, we might see a typical distribution involving the scalp, the face, even the palms and soles might be involved. So the typical, as I said previously, the typical clinical presentations are erythematous and excoriated, intensely pruritic papules involving the fingers, the finger web space, the lateral side of the fingers, the gluteal, the axilla, the male genital area, as well as the palm and sole in children. So this is the typical presentation of a classic scabies, and there are also a typical presentation of scabies like the nodular variants and also the crested variant. And this the nodular variant present with intensely itchy, persistent, and firm erythematous and or skin-colored, extremely pruritic papules. And this nodular scabies is more common or particularly seen in children, but not that common in adults. And this is usually assumed to be due to the hypersensitivity reaction to the mites, and the groin, the buttock, and the genitalia are usually the commonest site of involvement of this nodular types. And the other very variant, atypical variant, is a crested scabies, and this crested scabies, it's a rare and severe form of scabies, and it's characterized by infestation up to millions of mites, and it's highly contagious variant of scabies, and it's more common to see this variant in immunocompromised individuals like HIV/AIDS patients, leprosy, lymphoma, or old age patients. And this crested scabies is characterized by diffuse hyperkeratotic scaly plaques with fissures, and minimal is usually minimal. The pruritus is usually minimal or absent. Any area of the body can be involved, but the scalp, hand, and feet are particularly more affected, and the lesions are, in addition to that, more malodorous. This is a patient with crested scabies. As we can see, there are diffuse hyperkeratotic psoriasiform scale with fissure in the hands, and nails might also be involved. This is also another picture of presentation of crested scabies, and this variant is highly contagious comparing with the classic variants. So when we come to the diagnosis, normally in a clinical setting,
Sorry everyone for the technical difficulties. We'll be back.
can you hear me?
Yes, we can hear you now.
Okay.
Continue.
So the definitive diagnosis of scabies needs identification of the mite and its product like the egg and fecal pipe, either by microscopy, dermoscopy, or histopathology. But since the mite burden in a classic scabies patient is not that much, finding of this scabies mite or egg is usually not visible. So we usually diagnose scabies presently by relying on the history and physical examination, and there are some history on physical examination points that help us in order to reach the differential diagnosis. So for a patient presenting with widespread and generalized intense itching, which is worse at night, and a patient with a typical lesion with a typical distribution, and also a patient having a similar complaint in the household, these findings are suggestive of scabies. So in order to diagnose scabies, and definitively, as I said previously, we need to visualize the scabies mite and its product on microscopy and dermoscopy. So on microscopy, we can do either this scabies preparation by taking skin scraping. So this skin scraping it helps in direct visualization of the mite and its product for microscopy. And there are some high yield areas for this skin scraping or scabies preparation. Commonly, that's the web space of the fingers, the flexural wrist, elbow, and axilla are usually high yield areas. So these scrapings are better to be taken off from non-excoriated papules and burrows. So before taking a scrap, we can add a drop of mineral oil over the burrow, and we can just add this scraping over the glass slide, and we can examine it under microscope. But for a crested scabies, we can add 10% potassium hydroxide additionally in order to dissolve the skin. This is how scabies mite appears under microscopy. This is the mite, the adult female mite, and these oval looking things are the eggs, and these are the fecal parts. We can also do adhesive tape testing. This adhesive testing is similar to the skin scraping, but it's usually more preferable for pediatric age groups, and we can apply this adhesive tape to the skin lesion, preferably the burrows or the non-excoriated papules, and we can rapidly pull off and apply this adhesive tape to the glass slide, and you can examine it under microscope, but it is usually not really sensitive test. The other one is dermoscopic examination of the lesion. This dermoscopy is actually a helpful adjunctive diagnostic tool to examine the mite, but due to availability issue, we don't usually do dermoscopy for a scabies examination or diagnosis. So this dermoscopy will help us in direct visualization of the scabies burrow and the mite, but it's not usually possible to see the eggs and the fecal part under dermoscopy. So what we typically see on dermoscopy are this triangular or delta signs, this brownish triangular thing on the dermoscopy. This is what we call the triangular delta sign. It is the mite's head, and it's usually the sensitivity is low comparing with the scabies preparation, and also in a pigmented skin like ours, it's not usually possible to see the mite head. And in a crusted scabies, a noodle-like pattern is usually visible in the dermoscopy. And the other one is burrow ink testing. This burrow ink test usually helps us in visualizing of the burrows. As we can see, we can apply an ink over the burrow, and we can, after wiping off the excess ink, we can see this, which demarcates the burrow. And the other one is histopathology. We don't usually do histopathology or skin biopsy for scabies diagnosis unless we want to rule out other differential diagnosis. So if we do histopathology, we can see both the scabies, the mite, the egg, or the feces might be visible. In addition to that, we may also see epidermal spongiosis and diffuse dermal infiltrates. This is histopathology taken from a patient with scabies. As we can see, this is the scabies mite resides in the upper stratum corneum of the epidermis, and also we can see there is epidermal spongiosis and also diffuse inflammatory infiltrates in the dermis composed of this lymphocytes and also eosinophils are visible. So now let's go to the management part for scabies. So the successful management of this scabies involves the treatment of the or eradication of the mite. We have also to treat the pruritus. We have to manage the complication if there is any due to the severe or intense itching and excoriation. Secondary bacterial infection is also common in scabies patients. So treatment of any complication, if there are any, is also important. And the other point that we should really consider is treatment that close personal contact or household contacts. And the other one is implementation of environmental measures in order to minimize the transmission on recurrence of infestation. So before starting treatment, it's better to classify patients as having classic or crusted scabies, and the first-line treatment options are different in those groups. So for the classic scabies, the first-line treatment options are the topically applied anti-scabies drugs. These scabicides are both topically applied and systemic ones. For the systemic one, we have the ivermectin. So the first-line treatment option for a patient presenting with classic type of scabies is permethrin 5% cream. This permethrin is a topical synthetic peritidone agent. It impairs the voltage-gated sodium channel, leading to the leading to disruption of neurotransmission in a female mites. And it's highly effective with cure rate of exceeding more than 90%. In addition to this, this permethrin is also safe in infants as young as 2 months of age, in children, in pregnant, even in lactating individual. It's generally a well-tolerated drug, and the potential side effect is usually skin irritation. So we advise patients to apply this permethrin cream thoroughly into the skin, starting from the neck down to the soles of the face, including the undernails of the fingernails on the toenails. But in children, due to the involvement of this scabies and the scalp and face, we should advise parents to apply this cream into the face, scalp, avoiding of this perioral and periorificial area. After application, they will leave the cream overnight, and they will wash it after 8 to 14 hours. And this permethrin then will be applied repeatedly after 1 to 2 weeks. Normally, this permethrin is active against the mite and also the egg, but in order to eradicate the newly hatched mite, it's better to apply a second dose after a week. And the other option of first line or second line option for scabies is a benzyl benzoate solution. Normally, this benzyl benzoate solution, it's usually used in a low and middle income countries due to the low cost and also availability. And it's available in different strengths. We commonly use this 12.5% preparation for children and this 25% for adults. Normally, it's not used because of the intense skin irritation due to this lotion, and it's also contraindicated or not used. It's better to avoid in pregnant individuals, lactating mothers, and in children less than 2 years of age. In this age group, it's better to use permethrin on sulfur. So we'll advise patients to apply this cream daily for 3 consecutive days, like in the same manner like that of the permethrin. And a repeat treatment or a repeat application after 7 days is also important in order to eradicate new mites. And the other option of topical anti-scabies medication is sulfur. Sulfur is also available in different strengths, and we prefer the 5 to 6% strengths for pediatric age group and 10% for the adult. Another advantage or benefit of the sulfur is we can use it in those neonates, pregnant as well as lactating mothers. And it's also applied overnight in the same manner like that of the permethrin and sulfur. And it will be rinsed off every morning, every day in the morning for 3 consecutive days, and we'll apply it additionally after 1 week. And the downside of the sulfur is it's messy, so it might stain clothes. It's also malodorous, and it might be irritating to the skin. So the other treatment option for classic scabies is the systemic anti-scabic medication, which is ivermectin. This ivermectin, it's a synthetic macrocyclic lactone, and it has the advantage of ease of administration and particularly useful for a large scabies outbreak in which topical application of this creams is impractical. And it's also not recommended to use in pregnant or lactating women in those children whose weight is less than 15 kg. And this oral ivermectin for a classic scabies, it's given at a dose of 200 microgram per kg in a single dose, followed by repeat dose after 1 week, since this oral ivermectin cannot kill the parasite egg. So we should apply it after 1 to 2 weeks in order to kill the newly hatched mites. And so far we have seen treatment for the classic type of scabies, and the other one is a crusted variant. So for the crusted variant, combination treatment with both topical and oral ivermectin is a preferred first-line treatment option. The topical applied treatment can be 5% permethrin or benzoyl. It can be applied every day for 7 days, then twice weekly until cure. In addition to oral ivermectin, 200 microgram per kg per dose on 5 days, on day 1 to 8, 9. And on a patient with severe scabies, we can add additional 2 doses on day 22 and 29. And the WHO normally recommends mass drug administration in a place with highly endemic areas, or the prevalence is more than 10 to 50%. In these areas, it's better to give mass drug administration for the whole community in order to decrease the transmission. And for the mass drug administration, it's advisable to use a dose of ivermectin 200 microgram per kg. In addition to that, this the second or two doses of ivermectin, it's assist in preventing drug resistance, which is recently emerging in some areas. We can also use permethrin 5% cream for those individuals who are contraindicated to use ivermectin. And the other point that we should really consider management of the pruritus. As I said previously, this pruritus is due to the delayed type hypersensitivity reaction to the mite and its products. So it might stay even for weeks and a month after treatment. So during treatment, concomitantly, we can treat the pruritus by using both sedating and non-sedating antihistamine. It's preferable to use the non-sedating one in the daytime and the sedating ones in the evening. And even after the eradication of the mite, we can use medium to high potency topical corticosteroid. And for those patients presenting with severe and generalized persistent itching, we can use short-term course of tapering systemic steroid at a dose of 40 milligram per kg of prednisolone can be used. And there are also other topical treatment options that we don't usually use, like clotrimazole, malathion, and limdane. Normally, limdane is usually has fallen out of favor due to a risk of the systemic toxicity like seizure and death. So it's better to avoid this treatment options. And malathion can also be applied, but due to the high flammability risk, it's better to avoid this medication. So in addition to the treatment of the contact kit, it's better to manage the household contact as well as close personal contacts due to high risk of transmission and to break this transmission cycle. So all household members as well as close personal contacts who has a skin-to-skin contact in the previous 6 weeks should be treated in the same manner as the diseased person or infested person with the first line option of permitting 5% cream, similarly like the infested person. And in addition to that, all clothing as well as beddings, linens which were used by the patient should be washed at high temperature, preferably at more than 50 degrees Celsius. Or for clothes which can't be washed, we can keep them in a plastic bag for 3 days, or we can dry it outside in the sun for 3 days, since the mite cannot live off the host for more than 3 days. But for crusted scabies, we might need a little longer time, and we should also clean the room thoroughly for those crusted scabies patients due to high risk of mite burden, high risk of transmission due to high mite burden, and also and there are also recently emerging treatments which are under study. So the first one is this spinoside. Spinoside, normally it acts on the nicotinic acetylcholine receptor, and it causes muscular as well as nervous system impairment and involves muscle contraction and paralysis in the mite. The spinoside is available in a 0.9% suspension. It has recently been approved in US FDA for the topical scabies treatment, but still now it's not approved in our country. It's just under study. And the other emerging treatment is moxidectin. Moxidectin is also another it has high lipophilicity and it also has a prolonged half-life, giving the advantage of single dose application. And this moxidectin, it's a second generation macrocyclic lactone. It's similar to that of ivermectin, and currently it is US FDA approved for the treatment of onchocercia volvulus, and in fact it shows high efficacy for the treatment of onchocercia, but still not recommended to use in, or not incorporated in different guidelines for treatment of scabies. And the other one is ofoxolaner. It's commonly it is used for the treatment of fleas and tick in dogs, but currently it's under being studied for treatment of scabies in pigs, and it shows promising result. In fact, it is showing significant higher efficacy over ivermectin. So these are some of the preventive measures we can take in order to avoid the scabies. The first one is we have to advise patients to avoid close contact, and also to wash clothes which were used by the patient. Also, if for the clothes which can be washed, we should advise them to keep them in a plastic bag. And also we have to clean the rooms thoroughly, or the furniture should be vacuum cleaned, especially for the crusted variant of scabies. So this is all, and thank you for
Dr. Nafkot, if you are speaking, you are not audible, please unmute it. Hello, Dr. Nafkot. Okay. It seems Dr. Nafkot have had some technical difficulties. Dr. Yerus, could you check the chat box and respond to some of the questions?
Okay. Okay, thank you everyone for the comments. So the one question that I've seen is how often do you encounter patients with scabies in your clinical practice? Normally, it's a very common skin condition. It really depends on where we're experiencing. Usually, compared with the urban area, it's more common in rural areas and also in urban areas.
ድምፅሽ ትንሽ ይርቃል ዶክተር።
Okay. Normally, this scabies is a very common skin condition that we almost see it every day, but it depends on areas. It's usually more common in areas with low socioeconomic status, and especially in an overcrowding living situation. It's really common to see this scabies almost every day.
Okay, can you hear me?
Yes.
Okay, sorry for the interruption. Thank you, Dr. Yerus, for your nice presentation. Sorry for the technical difficulties. I just want to add a few more points. Even if, scabies is one of the neglected tropical diseases, and it's a major public health concern in our country. And even if the incubation is 46 weeks, when we encounter reinfestations, we usually see it within 1 to 2 weeks of exposure, okay? And also, regarding the management for specific populations, if you encounter patients, usually infant patients, it's better to use 5% sulfur. And in children and pregnant women, you can also use permethrin as well as sulfur 10%. And for mass treatment, as Dr. Yerus said, you can use ivermectin 200 microgram, and don't forget to repeat it after 2 weeks. If you have any questions, you can forward it. Thank you. Okay, we have one question in the chat box. Do you find any patients with scabies that have systemic complications? We usually encounter patients having these complications like impetigo, superficial skin infections. But when we have these neonates and infants having infection, we could have this systemic symptoms of infection. Otherwise, it's not common. Any other question you want to raise? Another question in the chat box is, what about scabies epidemiology in Ethiopia and major hotspot areas? It was mentioned in the epidemiology part.
Yeah, there was a study which was done in Ethiopia in 2020, and the average scabies prevalence in Ethiopia was around 14.5%, and those with Amhara and also southern region were shown to have higher scabies prevalence. Okay, the other question, is there any pathognomic sign for scabies? Yeah, as I said previously, finding of these burrows is really pathognomic sign for scabies, but we don't usually see this burrows due to extreme pruritus or excoriation, and also due to secondary infection. It might not be visible, but finding of these burrows in a typical distribution, like in a finger web, size of the finger, the wrist or axilla, is highly pathognomic for scabies. So for the other question, to confirm the diagnosis, we have to see the scabies, the mite, and also the products of the mite, like the eggs in the fecal parts, either on microscopy, dermoscopy, or histopathology. So the definitive diagnosis should be made after visualizing of the scabies, the mite, and its products. Okay, for the other question, for the management of the pruritus, the antihistamine, we can use the non-sedating one, commonly the cetirizine, levocetirizine, and you can also use hydroxyzine. Commonly, the cetirizine at a dose of 10 milligram per kg per day, or levocetirizine 5 milligram per kg, 5 milligram per day is usually enough for the management of the pruritus. And ivermectin is, oh yeah, it's available in our country. Is it common to find patients with skin infection? Yeah, secondary complication. The main complication of scabies that we expect is secondary skin infection due to the excoriation. And so the common complication is the skin infection like impetigo, but this post-streptococcal glomerulitis and other systemic scabies complication are usually not that common. I haven't seen so far a patient with systemic complication. So I have only seen a patient, scabies patient with a secondary skin infection, commonly this impetigo. Okay, had been supportive. Okay, for the other question, even if we're treated by, yeah, for this, one explanation might be missing of treatment of the contacts. We have to make sure to treat the contact cases, and also we have to make sure if the patient are applying the permethrin cream properly. We have to advise them to apply the cream properly, starting from the neck down, even below the finger, and the toenail should be applied. And we should also advise them if there are pediatric or children cases in the household, they should apply the cream in the scalp and the faces. And also this permethrin cream or BBL, it should be repeated after a week, since there might be some eggs or newly hatched mite that might be missed during the first treatment. So it's better to make sure if the patient applied properly about the cream, and we should make sure if the household contacts are treated properly. Okay. Yeah, that's the issue. The high cost of permethrin is what's really a problem to us. So in our setup, what we usually use is BBL or benzyl benzoate lotion due to the low cost of the drug. Yes, calamine can also help for the pruritus. Okay, for the other question, why is the itching more worse in the night? It's because the adult female mite is more active and it's assumed to be more active in the nighttime compared with the daytime. Okay, what measures are being taken? So on the national level to prevent scabies, one is health education, giving proper health education, and also mass drug administration since we are in a high endemic area for scabies, mass drug administration is also important, and usually it is advisable or implied by the WHO to give mass drug administration in a high endemic area in order to decrease the scabies prevalence. And the other one is health awareness, health education to the people.
Hello, Dr. Nafkot. Hello, please, if you are speaking, please unmute.
Hello, can you hear me?
Yes.
Okay, let me continue on some of the question. Okay, I'll share the link later. Okay, why do I apply a neonate cream? As I said previously, the most common involvement in pediatrics age groups, there is atypical involvement, like the scalp, the face, the palm and soles are usually involved, unlike the adult age group. So it's better to apply this anti-scabies drugs or treatment starting from the scalp to the toe, since there is high involvement of the scalp in the palm and sole. Okay, the indication for ivermectin for the classic type of scabies, for those if there is a large scabies burden or if there is the high scabies prevalence due to the ease of application, it's better to use ivermectin as a first-line treatment. And also for the crested variant, the ivermectin in combination with a topical permethrin or BBL is the first-line treatment. So the indications are for if there is high prevalence or mass for the mass administration as well as for the crested variant.
Also, there are some public health related questions, like integration of scabies management in primary health care, as well as the integration of scabies prevention and treatment in humanitarian centers like IDPs. What do you suggest? Hello, Scabies.
Yes, I can hear you.
On the public health issues, because it is a common problem in rural areas. So that's what you suggest, the integration management.
Yeah, this integration is very important, and also the WHO also has a goal for incorporating of this scabies treatment prevention or treatment guidelines in different centers and also in refugee camps, and also to treat applying or giving of mass treatment in this center is also important.
Other one is there any
Okay, I am actually seeing a question on what the place of Erox cream for the treatment of scabies. Yeah, I tried to mention in the previous slide, this Erox is a cotinetone lotion. It's also available in one treatment option, but not commonly used, but we can use it. About the question on the incidence, what I've gotten so far is the prevalence was done, or the study was done in 2020, but recently due to due to the wars and refugee and as well as increased in displacement, internal displacement, the scabies prevalence is currently increasing.
Hello, Dr. Nafkot, are you back? Hello. Okay, Dr. Nafkot might have got some bad connections. Dear all attendees, sorry for the inconvenience. Dr. Nafkot couldn't join us. Also, we had today some technical difficulties. For all the inconveniences, I will ask you just your excuse for today. We'll try to compensate these technical difficulties on the upcoming webinar. Hope to see you this afternoon. Just I shared the PowerPoint. You can download and read. Please try to download the PowerPoint for your reference. Thank you for your understanding.